All right, good afternoon and welcome to another edition of the Stanford Health Policy Forum. My name is Keith Humphreys. I'm a professor of psychiatry here at the medical school, and I lead the advisory group for the forum, which brings top health policymakers and health thinkers to campus to talk to the Stanford community and the broader community about pressing health and healthcare issues. And today's topic, which is the future of children's health in California, is certainly one of those issues that is very pressing, and it's hard to think of many topics that is more worthy of our time and attention and our thought. The forum is supported by the Dean's office, and our Dean is here, Dean Pizzo, so I can thank him in person. Thank you, Dean Pizzo, for supporting this series, and to the outstanding staff who put this together, Ryan Adesnik, Lucy Wicks, Leah Denman, and we had outstanding help also from Packard on this, Chris Dawes, who very much wanted to be here and had a conflict. He had to be out of town, and Sherry Sager. Thank you so much. The other advisors of the series are Mr. Bob Burke, Dr. Dan Kessler, Dr. Ann Arvin, and alas, Dr. Alan Garber, who is leaving us to go to Harvard to be their provost. And Alan was with the forum from the beginning for 5 years and has given us a lot of advice and assistance. We will miss him very much, and we wish him the best at the Stanford of the East. If you want to learn more about the forum, like see future events or watch any of the videos of past events, you can do that online on our website, which is Health Policy Forum, that's one word, healthpolicyforum.stanford.edu. So our format today is going to be our distinguished guest is going to open with some brief remarks to give her perspective, and then we will move to a panel discussion moderated by Paul Costelloe that will run about until the hour of 1. And then, as we usually do, we'll open it up to your comments, thoughts, questions, criticisms, and so on. Now, when we get to that point, please wait to be called on so that we can deliver a microphone to you, because we want to get your comments on tape, just as we do those of the panelists. So I'll start by introducing our distinguished guest. Immediately to my left is Secretary Diana Dooley, the Secretary of Health of California. She's had a long and very distinguished career in public service, going back to the first Jerry Brown administration when he was the youngest governor of California, 1975, where she served as his legislative director and special assistant. She also went into the private practice of law, which she subsequently became the general counsel and vice president at Children's Hospital Central California. And then she later was the president and the CEO of the California Children's Hospital Association, which advocates for children's health on behalf of 8 nonprofit hospitals. Another thing in her extraordinary career I noticed when I was reading the LA Times is she was also once an assistant fire chief, which has to be the perfect preparation for state government, I would think. Anyway, so please join me in welcoming her to Stanford University.
Thank you very much, and thank you for the opportunity to be here with you. I often say when I'm invited to join people they often say speeches, but I'm really not much of a speech maker. This conversation format is exactly my preferred style, and so I look forward to visiting with you and with the panel over this next hour and a half. There are so many important issues that we have to face, and my choice was a difficult one, to leave the work of children's hospitals to come back into government at this moment. But I do think, as I'm sure you do by your involvement here today, that this is a transformational moment. There are so many opportunities that we face, and of course the challenges that we experience are a part of the seedbed for the very opportunities that we will have to explore. So I look forward to that exploration a little bit with you here today, but the few comments that I wanted to make are the foundation. I come from a farming background, so many of my metaphors are agricultural, like the seedbed. And regrettably, we have a lot of rocks in our garden right now. And the work that we have to do on the state budget is foundational to everything else that we will do. As you may know, also, I'm the chair of the California Health Benefit Exchange, and we have the exciting opportunity ahead to implement healthcare reform here but we can't do it on the foundation that we currently have. And so as I've told my colleagues that are very eager to get started in healthcare reform, we have to eat our spinach first. And eating our spinach, unfortunately, and I hate to use that because I do like spinach, but balancing the state budget is foundational to everything we must do. And I often refer to the delightful piece that Maureen Dowd penned in the New York Times recently and said, Jerry Brown is no longer Governor Moonbeam, he's Governor Laserbeam. And I'll tell you, he is in fact focused like a laser, and that was made abundantly clear last week with his rejection of the budget that he does not believe sets us on the firm foundation that we need. So there may be questions about that, and I would be happy to entertain them, but I'm also very eager to talk about the very important subject of children's health and how we can create the right environment to be sure that our children have the opportunities that we as adults have enjoyed. So thank you very much for the invitation, and I look forward to the conversation.
Great. Thank you for joining us today. And Keith, are you going to introduce the
Yes,
panel?
let me go ahead and do that. So I'll just move from your left to right, starting with Dr. Paul Weiss. Paul is a professor of child health and society and a professor of pediatrics at Stanford. He's also the director of the Center for Policy Outcomes and Prevention and has made quite a name for himself, not just in national child health policy, but internationally. We're very glad he could join us. Immediately to Paul's left is Dean Pizzo. He has been the dean of our medical school since April 2001. Before he joined Stanford, he was the physician-in-chief at Children's Hospital in Boston and chair of Department of Pediatrics at Harvard Medical School. And he's internationally recognized for his work in children's health, particularly children's cancers and in infectious diseases. To his left is Dr. Shashank Joshi, an assistant professor of psychiatry and behavioral sciences. He has been the director of school mental health services in the Division of Child and Adolescent Psychiatry here at Stanford. And then to his left is our own Paul Costelloe, the head of media and communications at Stanford Medical School. Paul's had a long and distinguished career in media, including being the spokesperson for First Lady Rosalind Carter and for Ohio Governor Dick Celeste. So Paul, please take it away.
Thank you, and thanks for joining us. Why don't I show of hands first? How many of you are involved with children's health issues? So a large portion of the crowd.
That's great.
So they may have some very pointed questions for each of you. Diana, Dooley, I wanted to start with you and ask you, you've known Jerry Brown a long time, and how does he prioritize children's health issues, and how does he prioritize them in the middle of this economic hurricane?
I have known him a long time. I was a young analyst at the State Personnel Board when he was first elected and went over to his office in the fall of '75 on what I thought was a temporary assignment and stayed 7.5 years. He is incredibly curious. And I think that curiosity and the intellectual honesty of that curiosity informs any subject that he addresses. And I think in the context of children, specifically, he has been very, very committed to his two most cherished activities have been the two charter schools in Oakland that he founded and he continues to support. And interestingly, they're really quite different. One is a military school that sort of builds on the work that he did in his first administration founding the California Conservation Corps, taking those that are just about to fall into the basically criminal justice system and reaching down and encouraging them to have a purpose and a commitment through the discipline of the military school or the discipline of the California Conservation Corps. And his other charter school is about arts. And it's a charter school that is selective to get into it. Virtually all of the students that are graduating from there are going to college. And he's very, very proud of the college rate of his military school as well. So I would put his attitude about children's health in the broader context of the socialization needs as well as the health needs of children. As you know and your audience knows, most children are physically pretty healthy, and the issues that we'll address about their needs are specific to those that are not healthy. But there are many broader issues, and I was very delighted to see Shashank here to talk about the mental health needs of children. So I would put it in the context of a comprehensive approach to children's health, meeting their physical needs, but meeting their educational needs and their social needs and their welfare needs. And we could talk about some of the specifics, but that's how I think he approaches it.
You've been an advocate for children's health for many years, children's hospitals. I would think that it would be pretty difficult to be in the crouch position that you're in right now because of the economic condition of the state, and that you would much rather be expanding health programs than curtailing them and making tough decisions about what gets cut. So where would you say that we are in the state of California health for children today? Is it a good story? Is it a bad story? Is it a mixed story?
Well, I think it's definitely a mixed story. We have some extraordinary accomplishments of which to be quite proud. And of course, I start with my own basis of the California Children's Hospitals. There's no state that has as many or the high quality. So many are leaders in a variety of ways, and they work very cooperatively together. And I think as we look forward to healthcare reform and the relationship between physicians and facilities, the hospitals and the providers, all of American health would be well served to look at the model of the children's hospitals. And so I think we have a lot to be proud of in the treatment of our most seriously ill and injured. I think on the other side of that equation, we have a long way to go in primary care for children. The California Healthy Families Program, that is the implementation of the federal state insurance program for children, has helped, but there are very many children that don't have routine, ordinary care. And I've been particularly appreciative of the work that Dr. Weiss has done, over the years, and this way the pediatric practice has changed over the years, and the differences between the subspecialists and the pediatricians and the kind of care they provide. I think there are many opportunities in healthcare reform to look at our delivery of care for children, and most specifically in scope of practice and physician extenders and what we're training pediatricians to do, and yet what we're asking them to do in the ordinary course of treating children. So I'm very interested in the conversation with the panel, but I would say it's a mixed condition that we face in California.
To the other panelists, how do you see it? If you were to calibrate on a 1 to 10, with children being 10 being the most vulnerable, how would you characterize it, Paul Weiss?
The question is, which children? Overall, I could give us a 5 for the moment, but what I'm concerned about, where are we going to be in 10 years? And the way things are looking now, my concern is we'll be at about a 1.8 if we're not careful. Some of the best things, like the children's hospitals in California, are increasingly vulnerable to gaps in policies, inattention to what's really working and protecting those kinds of elements in our system. In addition, I worry that we're not taking full advantage of the opportunities to address the growing changes in the epidemiology of need in childhood. So I think things are maybe a 5 overall for kids today, but unless we change the way we're doing things, above and beyond the budget issues, my concern is that we're going to see a deterioration in the general health, and particularly in the general health of the healthcare system for children in California.
Well, what are the things that we need to change?
Well, the first thing to recognize is that we're confronted with the primary fundamental mismatch between our current structure of pediatric care and the very quickly evolving epidemiology of childhood. That our system of pediatrics was put into place in the 50s and 60s when acute infectious diseases, particularly in little kids, was really the central concern. When I was an intern decades and decades ago, that was our primary focus. That is largely evaporated. The chance that a previously well kid is going to get acutely ill from an infectious disease, get very sick, wind up in the hospital and die, It can still happen, but it is vanishingly small. What has become far more prominent is kids with serious chronic illness. And Phil and colleagues in Boston wrote about this very early on, the implication for pediatric training, more than a decade ago now, because we could see this train coming down the track. The problem is that pediatricians in practice are working in a system that was built in the 50s and 60s, and they have no capability, no reimbursement, no support structures to take care of kids with serious chronic illness. So the kids are floating out there without appropriate care. So number one is this mismatch. The second is the growing social stratification in our healthcare system for kids in this state. That there's a growing disparity in reimbursement between private insurance and public insurance, primarily Medicaid. And what you see is a growing detachment of the two systems, a growing concentration of Medicaid, of publicly insured kids into certain safety net facilities, and particularly the Children's Hospital for the kids who have really serious chronic problems. That can't be sustained. We have large health insurance plans in this state who will not take Medicaid, or very few Medicaid enrollees. And yet we have hospitals and other facilities that will basically have to subsidize the care for the Medicaid patients from payers.
Hospitals like Packard.
Hospitals like Packard, but not only Packard, all the children's hospitals. And that subsidization from the private insurers to pay for the kids who are being basically under-reimbursed for their care on Medicaid can only go on so long. At some point, the whole system is going to collapse. And don't be mistaken to think that there can be a high-quality tertiary quaternary system for rich kids and a failure of the safety net for poor kids. Just try to imagine what it would look like to have a rich kid trauma unit. Okay, you're going to see a lot of people in scrubs and clogs with tubes sitting around watching Oprah, because what's going to happen is you're going to see the deregionalization of pediatric care, and when that happens, the quality of services begins to fall because the facilities just don't see the numbers of patients that have these problems. They can't make the investment in the best people, in the best nurses, in the best equipment. And that requires a regionalized system of care that includes all children with these problems. So the mismatch of the structure to need and the growing social stratification in our system, to me, are the two primary challenges.
Phil Pizzo, what about that mismatch? How do you view it?
Yeah. So I'd add a couple of additional points to those that have already been made, because I think they've been extremely important and astute. And I would say that there are the following issues. One of them, as Paul alluded to, and certainly Diana spoke to, is there have been dramatic changes over our lifetimes. I actually began pediatrics before Paul, and when infectious diseases were the common problems. And I remember my first day in Boston as an intern, the second patient that I admitted was a child with Haemophilus meningitis. And we don't see that anymore because there is a vaccine that was developed against that. Just like we don't see streptococcal disease in the same way that we did before, because there have been immunizations for those illnesses that have had such a huge impact on the quality of care. What we do see are a number of challenges that are both related to underlying problems as well as ones that we've created. So the underlying problems are, there are diseases that still affect children and have catastrophic implications for which the outcomes have been significantly better than in years past. So I began my work in the area of pediatric oncology. When I started in the early 70s, most children died. Today, most children survive, and they survive with a whole series of chronic disorders as a consequence. When Dr. Obrodovich, sitting in the audience here, now the chair of pediatrics at Packard, began his career, most children with cystic fibrosis died. And today they're living into adulthood. When I was working on HIV infection, most children died, and now they're surviving as well. So we have a cohort of childhood survivors who have chronic problems that are marching through the groups, and they're going to fall through the safety net as well because there aren't providers to care for these children becoming young and full adults. And I worry particularly about those who have neurodevelopmental problems that have easily become the orphan of both pediatric and adult care. So that's one group that I think we're going to need to pay attention to. And all of us recognize that in the healthcare system, it's a small portion of patients who constitute the vast majority of costs. And then I would say the other is our societal effects that are altering childhood wellness. And this not only relates to education and behavioral consequences, but the one that looms large for all of us is obesity. And obesity is going to carry many other consequences associated with it. And yet, in many ways, it doesn't have to happen. It's happening because our children and our societies are, in a sense, because of the both social consequences that they find themselves in and the exploitation that takes place because of the fast food industry, and others are being subject to meals not even on wheels, but meals that are affecting their wheels in very significant ways. And here I think we're looking at the intersection of the marketplace and of childhood. And we need to pay attention to these forces as well, the sort of psychosocial, societal effects, which will alter the complexion of disease and the chronicity of disease and the way we care for it. So I think those are additional things, Paul, that I would add to this equation.
You know, you raised in both of them, are you afraid, as Paul is, that this system is about or can crash? Are you worried about that? I mean, you talk about the long-term fiscal issues that arise when you have children become chronically ill adults. What is the fiscal impact upon the system, and will we be able to sustain it?
Yeah. Well, you know, to start with, at a macro level, despite the Affordable Care Act, we're still without a healthcare system in this country. And one only can hope that there will be a migration toward a more rational approach to healthcare. Right now, we're still very much products of fee-for-service medicine, and we're very disease-based in how we manage children. And we think still, even around hospitalized care as the center orbit of what we do, and yet most of our children and families are going to be cared for in very different kinds of systems. So we need radical change in healthcare writ large. And children are often left to the side of that debate. I think we need to recognize this, and I'm looking at Sherry to even to account for the fact that when we're looking at the support for the future pediatricians who are going to care for children, that our own federal government, in fact, an administration which I, without getting overly political about, still support, left out children's hospitals, graduate medical education from the funding scheme. This is a really bad decision that has huge implications going forward. So if you look at it from the point of view of federal support for children, state support for children, you know, we're 50th in the nation in our in Medicaid and how, or in Medi-Cal in this state in terms of how it's funded and supported. We have some very scary times before us. That I agree.
Shashank and Joshi, there have been in the past few years a number of suicides in Palo Alto among teenagers. And what do we know about why kids kill themselves? And, you know, I've heard a psychiatrist friend of mine said that stressed kids don't kill themselves, depressed kids don't kill themselves. And what's the difference between a stressed kid who's feeling overwhelming academic pressures and a depressed kid?
Well, before a teenager is contemplating something as extreme as self-harm or actually wanting to kill themselves, there are a variety of factors that happen. This doesn't pop up out of nowhere, and one of the things that we try to do in our team, the school mental health team, Lucille Packard has had one now, a pretty robust one for about 10 years, is really trying to help not only students and parents, but especially teachers and schools understand the contextual factors that could lead a teen to contemplate something like that. And so while the great majority of teens everybody has to deal with stress management and figuring out ways to cope and ways to develop resiliency kinds of strategies, we think really is an important part of being a teenager. And so in our community, we've had, many of you know, 7 deaths by suicide in the last 2.5 years. We're still in an epidemiological cluster. The rates are 20 to 25 times higher than what you'd expect in terms of completed suicide among adolescents. And the greatest risk probably, in addition to the fact that we have a cluster, because that makes that method or means that much more accessible, but also for someone in pain, it may seem like that is a reasonable choice, is the idea that 75 to 90% of people, both teens and adults, will have had a diagnosable mental health disorder for at least a year. And in our detailed work investigating the deaths in our community, we are finding that number to hold true.
Well, why is there this notion that, people seem to be very surprised when a kid kills himself and says, we never knew, no warning signs, but you're saying something quite the contrary.
Well, a lot of the disorders that we see, depression, anxiety, and associated conditions, are what we call internalizing disorders. So the teen may seem on the outside to have it all together and to really be either very popular, very well known. In some cases, other people are going to those teens for their own support. But you really need just the wrong combination of brain, genetics, environment, and interpersonal factors to come together to lead a teen to start contemplating their own death. And we actually think about things like depression and anxiety as chronic illnesses as well, because they tend to be, they sort of have flares, they come seasonally. There are some medical factors, some psychoneuroimmunologic factors that can bring, for example, spring tends to bring more thoughts of self-harm and even suicidal acts, and there's been a lot of research looking at why that might be. But ultimately, you really need all of those factors to come together. And to go back to the agricultural metaphor you were talking about, there's a wonderful psychologist in Berkeley, Michael Riera, who talks about this concept of sediment and sedimented stress. So, everyday stress in the environment of a teen right now in spring, around, graduation or thinking about the college trips with their parents, or more commonly things like, what's going on in their sports teams or boyfriend-girlfriend rejection or things like that. Pretty common for teenagers. When you take that kind of everyday stress, which needs to be managed, and you put it on top of the sediment of other kinds of stress, say there's, your parents have lost their job because of our current economy, or you've had to move, you're going to have to move from your district, or you don't get into school you want, and there are some important family factors for that. There may be divorce, we've had a lot of anniversaries of the kids who've died. These sedimented stressors that they really don't have control over, when you put those everyday stressors on top of that, then that can create an environment that feels unmanageable to a teen who may be struggling with their own mental health issues. So for the majority of the teens, they find ways to cope. They may reach out to a friend, they may reach out to an adult, maybe not at home but in the school environment. But for the vulnerable teen, and again, it doesn't discriminate. I mean, we've seen suicidal attempts and completed suicide across the ethnic as well as socio-demographic spectrum. These issues, when they come together, can be problematic.
Diana, Prop 63 passed 4 years ago, and it allocated 1% of, I don't know if everyone in the audience knows, 1%.
Actually, 7 years ago.
Pardon?
It was actually 7 years ago. It's
7 years ago.
Hard to believe it was in 2004. It's been quite a long while.
Wow, it has been. What's been the impact of Proposition 63? Proposition 63 taxed millionaires 1% of their income with all of those funds to go into mental health services. What's been the impact of those dollars?
It's actually 1% over $1 million.
Over $1 million.
So there have been significant funds raised by that, and one of the conditions of that initiative, it was a voter initiative, was that those funds have to go to new programs. There was a maintenance of effort requirement so that all of the ongoing care that was being provided or not being provided, as we've seen since then, the new funds could not be used for that purpose. And so there has been some sense that the underfunding of the programs that were already in place has continued while we've had an overlay of additional funding. That's one of the structural flaws of the initiative process. It makes sense to a few people who design it, and it gets enacted. Darrell Steinberg is the senator from Sacramento who is the president of the California Senate now, and to his great credit, last year and again this year in this budget crisis, and he was one of the sponsors of that initiative. His passion has been addressing mental health. He has been the leader in setting aside that provision that it can only be used for new program because of the seriousness of the deficit. So some of those funds are flowing to the counties. But even with that additional infusion of cash, the need far exceeds the ability that we have to address it. We're working now with the State Department of Public Health on looking for some measurements to show how much beneficial impact has resulted from that initiative. But as I'm sure you recognize, being in this field, it is very difficult to make a difference, particularly in a short time, even though it's been 6 years or 7 years since it was enacted. That's a pretty short window to show the real lasting impact of that. I think one area where we have some opportunity ahead is in the requirement of parity between mental health treatment and physical health treatment. It's included, it's already law in California, and it will be a part of the federal Affordable Care Act. But as Paul Weiss was, pointing out so rightly, we don't have enough resource in the physical health field either. So we're going to spread this insufficient resource more broadly to more services. But as we look at the health benefit exchange and look at minimum benefits that are going to have to be offered, mental health will be a part of the package that will be required. I think one of the biggest challenges and opportunities that we face is in the reform of the delivery system itself. And it's been alluded to by both Pauls in our financing system that's related on units of care, the fee-for-service system. So we're paying for quantity and not quality or outcomes. The idea that we would move toward a system of outcome measurement that would incentivize the system to manage the care of the whole person, both mental health and physical health, is something that I think is an extraordinary, both, as I said, opportunity and challenge. And I think we have to really rethink what happened over the last 20 years in our concept of managed care. Managed care became a euphemism for the insurance companies to not authorize, to limit care. It was a financing system, and there was deep resentment. And Paul Pizzo talked about the change in the system here with regard to the way people view their care. We're really going to see some changes if we move to a system of care management. And the biggest difference in what the federal reform effort describes as care management is care management led by the providers instead of care management led by the payers. So in the 90s, we talked about managed care, which was capitated plans, and the insurance companies would decide what care one needed. And they had medical staff, but never enough, and there have been disputes between the medical staff by the payers and the medical staff by the providers. The accountable care organizations or medical homes or bundled payments, all of the language that's used around federal health care reform anticipates that the care is going to be managed by the providers of the care. And I think that has some real implications for improving care delivery, but also putting a burden on the trust relationship between the patients and the care providers. The need to, we still have, Paul talked about a rational system of healthcare. That seems sort of like an oxymoron given our history. It isn't rational because we have a false marketplace. We don't have a marketplace where, as a consumer, you can decide what healthcare you want and how much you're going to pay and who you're going to pay. We buy insurance, and the insurance company then provides a certain amount of healthcare, and the disputes are between the providers and the payers, and the consumer is left out of it. And the three legs of the stool in healthcare reform are coverage, which has had a lot of attention, but also provider delivery reform and patient behavior. And we've started talking a little bit this afternoon about patient behavior, but changing the patient behavior, whether it's lifestyle and obesity, it's also in terms of how much and what kind of health care do they want delivered. As I know you know, people walk into their doctors all the time with their printout from WebMD, and they know what's wrong with them, and they know what drug they want, and they know how many CAT scans or whether they need an MRI, and it's set up an expectation challenge that I'm very interested in hearing from the panel how you're dealing with that in medical education and in the practice of, we talk about evidence-based medicine. Evidence-based medicine means there's evidence for the procedure, but that doesn't mean that the patient's expectation is correct. And I use an example of there's a study a couple of years ago about mammography, and women in a certain risk pool don't need annual mammograms. I just turned 60 years old, and 2 years ago when that report came out, I met none of the risk factors. There was no evidence to support an annual mammogram. So I skipped a year in my mammogram, and I was just panicky until the 2-year anniversary when I could go get a mammogram. So my expectation was that I needed an annual mammogram, even though the evidence said I didn't. And so I think that we need to be thinking about how we're going to have honest conversations with our patients. And those of you in the white coats, I think, have a particular responsibility to begin this conversation with the patients if we're ever really going to reform our healthcare.
Phil Pizzo, what is that conversation?
Yeah, well, it begins at the very onset of education. I think you're correct that we've lived with and, in fact, grown up in a system where doing is either easier than reflecting, quite honestly. And even today, when I'm on clinical service or rounding with students, the first discussion is usually around what tests to do. And we have a routine actually that I do with the chair of pediatrics, where we meet with third year or students in their clinical pediatric clerkship. And we go through an unknown discussion, patient unknown to us at least, and the first reflex is almost always toward ordering the CAT scan or ordering this procedure. And our approach is you could actually make the diagnosis more than 80% of the time just on the basis of the history, and you can supplement it with an appropriate physical exam if you have the time to listen and do that information. And the laboratory tests are really supports for that. The reality is that our system over the decades has been enculturated into doing more than to listening more. And quite honestly, our patients and families have come to expect that as well. And this is not a new thing. I could remember—
That's why they bring that list.
Well, I could remember, you grew up on a farm, I grew up in the Bronx. And I could remember when doctors made house calls, and the doctor would come to our house, and if he didn't, and that they were mostly he's at that point, if he didn't do something, like give you a shot, they weren't going to get paid because they hadn't done anything. And that's been part of the system that we've enculturated our society with. And that expectation of thinking about health, of moving away from the next procedure or the need for coming into the hospital is going to be the only way that we're going to control the escalating costs of care and, quite honestly, improve the quality of care. Because even with our escalating costs of care, we are still far worse than most other nations in the world in our outcomes. So it's not just about money.
You'd be happy to know that At Einstein.
You got shots too?
Where I went to, I actually did my pediatrics training at Einstein as well.
It's in the Bronx, by the way.
So this is at Jacobi Medical Center, Montefiore, in the 90s when they were fused. We still made house calls. And so part of how I was trained, first as a pediatrician and then as a psychiatrist is really, I was kind of bathed in that whole, how do you deliver culturally effective care? Well, you have to start with the family. And so in the training programs here, I think I can say with confidence, having been involved with both the pediatric and psychiatric training programs, that's been a really important part of, I think particularly in California, with the changing sort of cultural diversity of our patients and hopefully our providers, that's a real kind of planful effort around being able to not only think you're doing a good job, but if you're talking about outcome measures, you might think that the message got through, but did the message actually get through?
Yeah.
Well, one of the ideas of the accountable care organization or bundled services to have the provider community in charge of the care instead of the payer community in charge of the care is the recognition that you can have an expanded role for the caregivers that are under the supervision of the medical staff, for example. And we're seeing in the primary care clinics a great use of the promotores in the Spanish language communities where they're using the history of the volunteer family advocate to help get the care at the right place at the right time. So I think there are some opportunities, but there are some significant challenges as well.
Paul Weiss, you wrote a paper last year, and you said something that really surprised me. There used to be something called a child health policy. It doesn't exist any longer. What happened?
Cost containment happened. Child health policy used to be a comprehensive plan, analytic basis for improving child health in the United States. With cost containment becoming the primary priority for a healthcare system, the focus has turned to where expenditures are largest. Kids are cheap. Most of us here are worried about children's health, but it's really, the technical term is budget dust. You could add up all the neonatal intensive care unit expenditures, all these super quote-unquote expensive premature babies. It's a rounding error for Medicare, the public program for the elderly. Nobody cares about the expenditures for children because they don't cost anything. So when the policy is focused on cost containment, kids basically fall off the radar screen very quickly. And what's happened is that basically what we have now is adult health policy being applied to children, almost as an afterthought. So the accountable care organizations, there's a lot of activity, a lot of planning. It's all focused on adults, the elderly, disabled adults, and then, oh yeah, we'll do something with kids too because there's a program for kids. It's almost always an afterthought. And in part, it's because the focus is where the action is, which is in cost containment. It's with the elderly and disabled adults. But it's also partly our problem. That in fact, the biggest problem for children, in fact, occurs because of all the people sitting in this room. And that we have become a highly fragmented constituency that in no way as unified as we used to be. Subspecialists are off in one direction, children's hospitals in another, primary care, if they're represented at all. There's almost no analytic work going on in the United States focused on improving child health. There's an opportunity for leadership that we have not fundamentally addressed, and that will require a more unified voice in the public sphere and a more unified, more coherent analytic basis for creating what would truly be coherent and informed child health policy in the future.
Phil, you want to make a point there?
I do. I think Paul's comments are well taken, and I certainly agree with those. I want to harken back, though, to a point you made earlier, and that is that children's care, and I'd be interested in Paul's reaction to this, in some ways could be looked at as a model for how healthcare could be delivered. And by that I mean that the balance between primary and specialty care is quite the opposite of the way it is in adult medicine. The competition in adult medicine is very specialty driven. In fact, most people who go into the care of adults are focused on specialty care primarily. And it's very fractured care. If any of us or any of you, or I suppose me, since I'm now moving into that senior group, need health care for multiple disorders, likely you're going to be seeing multiple different specialists who don't coordinate the care at all. And this is a very both expensive model and a very patient-unfriendly model. Well, the pediatric approach, which is, use the term the pediatric home well before it became popular as part of healthcare reform, and the more rationalization of central centers that deliver high-level care, and the distribution of trainees, which are much more primary as compared to specialty, is a very different template. And I think that there are lessons to be learned from that could apply. Now, they need to take into account the very issues that you alluded to, Paul. But I think we at least start at a point where it's a system of delivery that has some rationalization, however we got there, from which we can extrapolate from into other sectors. And it does take into account family and societal issues more specifically and broadly, and is inherently more humanistic and caring.
I wondered if each of you would reflect on a new study that came out last week, a New England Journal study that says that sick kids covered by Medicaid wait twice as long to see specialists if they get in to see any specialist at all. And the Illinois study, it was Illinois-based, indicates that there's an alarming and growing trend with specialists who are refusing kids who are on public insurance plans. And with cuts in Medicaid, I think there are some $90 billion in cuts in government funding over the next several weeks. Is this the new normal for kids who don't have private insurance? Phil?
So, part of it starts with the fact that there are relatively few specialists in pediatrics to begin with. In some areas, pediatric psychiatry, neurology, these are really pulmonary medicine. These are not very abundantly available just to begin with. So that's problem number one that has to be addressed. The sad story is problem number two is depending upon where you are in the system, if you're in California and receiving Medi-Cal and you're looking at professional reimbursement for physician's fees, it's way below cost. And if you're struggling to try and maintain a clinical practice, you can't really get by on that alone. And that is leading, unfortunately, to physicians making decisions about who they care for. That's one of the reasons why safety net institutions like the children's hospitals, whether it's Lucille Packard Children's Hospital or Oakland Children's or others in Southern California, don't deny these children, but it does come with a cost. And the cost is that they have to come up with other ways of paying for the difference, or else over time, to your point, they won't be able to make it.
Diana, what is the state's role here? If you were to learn that same information here, get that same data, does the state have a moral responsibility? Does it have a regulatory responsibility? How does it ensure that these access issues don't grow exponentially as these economic problems grow?
Well, we do have a responsibility, both moral and regulatory, to assure that there is an adequate access. And for the reasons that Paul said about it's nearly impossible for many pediatric subspecialists to sustain an independent practice. So they work together with each other through networks, primarily through the children's hospitals and the teaching hospitals. And that's where all children get referred for that specialty care. And so it's not just Medi-Cal children who have long wait times. Many privately insured kids have long wait times for some subspecialties. There are some subspecialties like gastroenterology where a pediatric gastroenterologist can make it with an adult gastroenterology practice, and they survive outside a clinical or academic setting in a children's hospital. But one of the problems is that because of other market forces with children that end up with chronic conditions or need high levels of subspecialty care end up on Medi-Cal, even if they're in a family with a working family that has insurance. They fall out through
Moderate
the lifetime.
income families.
Moderate income, or even high. I mean, the lifetime caps on their insurance kick in very quickly with a special needs child. And so the disproportionate number of children with special needs that are in Medi-Cal is directly affected by our overall problem with not having universal coverage. The lifetime cap may have been one of the most important aspects of the Affordable Care Act to go into effect before 2014, keeping kids on their parents' plans until 26. Both of those have significant impacts, but only if you also take care of the lifetime cap. These kids have a lot of care, so more and more of them fall into the government-sponsored care, which in California is Medi-Cal. The adequacy of the network is it is very torn, and we've tried very much in this current budget to preserve the safety net as much as we can, and we're doing everything. I mean, just to digress for a moment, but the tax rate in California today is at the level it was in 1972 when you compare the tax to $100 of earned income. We can't have 21st century care with a 20th century tax policy and the amount of revenue. At the same time, we're increasing cost in prisons because the courts have stepped in. We don't have that protection here. And so the social service network is very fragile. And I share the concern that all have expressed here today. But if we can't make that risk real to voters in California and to the people, whether we have a special election or not, as we pull further and further away from government and the distrust of government, we are not going to get the political will necessary to make the changes that are needed for kids.
I would imagine that a convicted felon in California, because of the court mandates, is in a better health care position than an indigent child.
Well, I don't know. You need to talk to the courts that are
I would
overseeing
assume
the prison
that.
health.
Paul,
I don't
you
think
had,
so.
is this the new normal?
No, I think the trajectory is deterioration from the current normal. First thing to point out, though, it's useful to underscore how important it is to have leaders like Diana available at this opportunity to make real changes, somebody in leadership position with a moral commitment to the health and well-being of poor kids. Don't take that for granted. The second thing to note is that our center does research not on the health of any individual child, but the health of the system that's supposed to be delivering care to children in California. And we've been doing research on these kinds of issues with particularly my colleague Lisa Chamberlain right here and Vandana Sudharam in our center, looking at these kinds of trends. And interestingly, particularly in the paper that Lisa took the lead on, is that if you're privately insured, you may have pretty good access to a subspecialist for opinion or office visit. But if you're going to need hospitalization for a serious chronic condition, you're better off with Medicaid, because the privately insured kids are more likely to be held in non-Packard children's-like hospitals, in more community-based hospitals, because their insurance is darn good. And the Medicaid kids get sent to the children's hospitals. And in those kinds of situations, what we're seeing is a concentration of the publicly insured kids more and more to the tertiary facilities, quaternary facilities like Packard. And the cross-subsidization, the anomalies in the system are becoming worse and worse. Now, the reason why the Medicaid kids tend to do better in California in being admitted to where they should be admitted is the California Children's Services Program, the CCS program, which has been in place for quite a long time. And when you look at the data, it's like the CCS program's got their fingers in the dike against this growing social stratification in reimbursement and other types of policy. if the CCS program is going to be changed, which it, in my view, should be, it must be done in a way that protects what's really good about this system and not undermine these kinds of protections that have been built in. We know that 1% of the kids in the CCS program account for 33% of the costs. 7% of the kids account for 60% of the costs. This is a very special opportunity to create new programs, new innovation. We're sitting in an engine of innovation. What the failure is a failure of leadership on our part to take these issues on, to create new programs, to create new opportunities, to work with county, state agencies, the other children's hospitals on a regional or a statewide program that will create the protections we need as well as generate the innovation that's going to be required.
Where is that failure of leadership? Where is it at all levels? Is it at the federal government? Is it at the state, the county level, schools? Is everyone responsible?
I would add providers. In all fairness, I think that the people here and that Paul is referring to, and I represented providers, and the California Children's Services Program was founded in 1927, and until, actually it changed names when the governor was the governor the first time in the late 70s, it was the Crippled Children's Services.
Yeah.
That's how it started, Crippled Children's Services. And it became California Children's Services when we weren't dealing just with polio, and it was primarily orthopedic. Really, for the first 60 years it was in existence, it was almost exclusively orthopedic. But in the theme or the theory of taking care of the children with the most critical needs, which were orthopedic, like Paul said, everyone else died. But the kids now who have, we have the medical technology and knowledge and advancements to actually heal these children. The services have expanded, but there is currently a request for proposals to pilot some innovations in the Children's Services Program, and I think that's what Paul was referring to, and it's going to require a lot of leadership on the part of the people who know the most about it, the providers. The hospitals and the physicians and the clinics need to partner to come back to the state with proposals on how they can make this system work more efficiently, and we're very eager to do that in partnership.
We've talked about a lot of the challenges today, so let's end, before we take questions from the audience, with what's on the horizon, the future, that really excites you the most? Why don't we start here?
Well, you know, in the being in sort of the wearing a pediatric hat and a psychiatric hat and a training hat, some of what I'm seeing, which I'm excited about, has to do with some of the ideas that actually started with the premise of the Mental Health Services Act in 2004, which was around the idea that, if we're talking specifically about two of the 5 main issues, one being that there would be an expansion in the community systems of care to a more integrated way of delivering services, and it brings me back to the medical home kind of model. But in my world, I think a little bit, and it ties to point number 2 of MHSA, which was around workforce education and training and retention of people who are really good, by really helping them to deliver what we would call evidence-based care, and not just simply doing care as usual if we really don't have evidence it works. But for example, in the schools, and there's been an expansion now of close to 200 school-based mental health centers in the last couple of years, that where you can really develop a sort of point-of-care kind of service. In the ideal, you would have a situation where you could have the mental health providers located on the school site, because even though only about half the kids who need mental health services get them in California, a little more than half, most of them actually get their services in the school setting, whether that be from a counselor or from a school-based psychiatrist or someone else. And so I'm encouraged by the idea that this was a specified area within Prop 63, and that there is a lot of energy there around trying to decrease both access to care problems that the kids have, but also destigmatization, helping teachers and other important adults to help kids be healthy enough to learn, to really be able to access the curriculum. And although some have said, well, schools aren't really primarily in the business of mental health care, I agree that's true. I think, but schools need to be able to help kids to access the curriculum. And so I am seeing some positive movement there, not only locally here, but also statewide in terms of what some of the other regional providers are talking about.
Would you mind if I jump in? Because
Sure.
I'm going to forget, and I didn't bring a note. A couple of points to that. As a part of our budget proposal in January, there was what we call realignment, which was the changing the nature of the relationship between state programs and county programs, and mental health and community-based services was a key part of that proposal. It's now pending until we can get the budget done and the tax extensions, but recognizing that behavioral health has been integrated at the local level for far longer than it has at the state level between mental health and substance abuse programs. And most counties have behavioral health programs at the county. Part of our proposal is to move those completely to the local level, give them the authority and the funding to operate at the local level. And the second reform relates to what you're talking about. There's an old program that was started in the early 80s called 3632 that has gotten so tied in a tight knot between the schools and the county mental health and the county welfare departments over kids' needs that we have proposed unraveling that and giving the schools the clear authority. They get the money, they call the shots. Now, the point I want to make about both of those, because it's exciting, because it empowers the local level, but it also runs counter to a concept among professionals of what I call statewide-ness. There's a sense that we have to do the same thing everywhere, and that those counties that are leaders will become magnets for the counties that don't have the political will or the resources to provide care at the same level, so their citizens will migrate to those counties that are doing it right. And so there's a caution, there's a give and a take with this local control, which this governor is very committed to local control, and our mental health policies are the first out of the box, public safety and mental health, that we're trying to move first on, but with the caution that it is going to result in things being done differently in Santa Clara County than they are in Tulare County, for example. But I did want to comment on both of those mental health issues because they are exciting. I think we have a lot of opportunity.
Phil, what are you most excited about on the horizon for kids' health?
I remain very much an optimist, and I think that certainly there are lots of challenges that we face, but having lived through so many awful times where the times themselves catapulted us into new phases of innovation and discovery and their application, I think that will happen here as well. We can't seek the alternative, right? I mean, that is a moment for despair. I think what we need to do is look at the challenges we have now, and I'm always hearkened by, the young people who are coming up through the system untainted by past ills, who will want to see the world differently than it's been today. And I think that there are better ways of delivering healthcare. We know that. We have the models, and we have thoughts about at least the models of how we can do that. I agree with you that local experimentation is a great way to do that, and I do feel that we can come out of this well.
Great.
Paul Weiss?
Believe it or not, I too am an optimist.
And I'm optimistic to know that.
Very much so. The people that work with me closely know how optimistic I am.
I do know.
This is a very special historical moment. Our technical capability to improve the health and well-being of kids has never been as large as it is now. It's going to undergo unprecedented growth over the next decade. I'm extremely confident that there will be major breakthroughs, many announced in this very auditorium, regarding a lot of different pediatric conditions, including precursors to adult onset disease and how to manage them in a pediatric setting, things like obesity, which is going to be crucial. However, in a highly stratified delivery system, new technical capability is more likely to widen disparities in outcome than reduce them. And the non-provision of technical capacity to all those in need, in my view, is profoundly unjust. So to accompany, joined at the hip, this growth in technical capability must be a renewed commitment to enhance, improve, and bring true equity to the provision of this remarkable new technical capability. through public programs like Medicaid, through CCS, and a whole range of new programs that we've not yet come up with new acronyms for. But what makes me optimistic is particularly being here at Stanford, at Packard, in California, we have the opportunity to create national leadership with a linked relationship between the technical capacity growth coming out of medical schools like Stanford, the delivery system that in many ways at the forefront places like Packard, and a research community focused on ways to create new evidence-based, innovative ways to deliver services. I am optimistic if we can get our act together. That will require a unified voice in the public domain and a unified structure for the creation of the knowledge, the social strategies, and the political will to create that leadership for years to come.
Diana, I wonder, Paul talked about, and Phil and others, about optimism. Sitting in Sacramento today, can you be an optimist? Are you able to be an optimist? Do you get up every day and say, I'm an optimist? Or how do you feel about?
I think I'm actually a cross between Pollyanna and Scarlett O'Hara. I'm very much an optimist, and my glass is always half full, and I always believe that we're going to get there, and I trust what people say, but verify, the trust but verify. But I'm also Scarlett O'Hara. I'm going to worry about that tomorrow. I've got such a full plate every day with what I can do something about that. I don't fuss too much about what's around the corner. If we need to get this budget done, if we don't, we'll do something else. I've always been, if the door is closed, I turn around and find another one to go through. And so I think that's part of an optimistic spirit. And I don't think you can do the work that we're doing, the work that you're doing here, if you believe that you're on the downside.
Right.
You've got to be on the upslope, or you just don't do this kind of work.
That's right.
Great, thank
So
you.
I'm
Thank
eager
you.
for the conversation.
Thank you, panel, and we're going to take questions now from the audience.
Thank you very much. I am glad that you mentioned obesity because it turns out that fast food and inexpensive sodas is less of a cause of obesity, according to the peer-reviewed secondary literature, than income inequality. You can have fast food restaurants and cheap sodas in countries that have less income inequality, and there's much less obesity. And that plays into 6 specific policy objectives I'd like to mention very briefly. And my question is, which are going to work, which might not? So first, in California,
Please keep it short so that people
right, in California, we could institute a 2-bracket income tax. There are probably people in this room who could put that on the ballot with their own funds and not even have to worry about any dent to their retirement or their families. So a 2-bracket income tax like Sweden's, where there's a 0% bottom bracket covering more than half the taxpayers, saves paperwork, and is also the most progressive income tax possible. We need to get into that and away from regressive taxes like sales and property taxes in order to get greater income equality. Secondly, both in California and nationally, single payer. I don't know if you've all used SimHealth. This came out in 1994. It's a game from Maxis, the people that did SimCity. It basically says if you don't pick either Canadian-style single-payer, universal coverage, or another thing that's about the same, then everything goes bankrupt as soon as the baby boomers retire. And that's what we're actually seeing happening. And all the peer-reviewed secondary literature agrees with that. So, of course, with fee-for-service or the exchanges, you might want to think that you would be able to charge obese people more, but that's not going to work in the courts or actually as a medical solution to the
Let
problem.
me ask you if you have a question there, because other people are going to want to ask questions.
Right, I told you the question is which of these are going to work, which aren't. There's only a few more. Nationally,
I don't want the whole time to take.
okay, very briefly. Repeal graduate medical education caps instituted during the potential physician glut of the 1980s. We need to reduce our tax. We need to realize our taxes are being used to limit the number of doctors which schools can train, and that just doesn't make sense anymore. We need to adjust the reimbursement rates to encourage more physicians to become general practitioners to meet the demand. And we need to use the courts to correct income inequality problems with healthcare, just as they have had success in education. And my question is, which of these ideas do you think are going to work, and which do you think aren't?
I only counted
Who's out there?
5, but my answers are yes, 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 maybe. I don't mean to be, make light of the points, the very serious points you've made, but many of us have been struggling with these kinds of issues for a long time. And the development of the political will, as well as the evidence base, is also crucial. And we have not done well, except for certain states, in moving some of these things forward. My expectation is that these things will reemerge as politically viable opportunities at different times, and that each of us contribute to ensuring that the conversation that accompanies these kinds of suggestions is constructive.
I would say that the issue of the perfect being the enemy of the good seems to resonate through the theme for me of the things that you identified, and I'd say specifically with regard to a Canadian-style single payer. There are many advocates of that, and a great deal of energy has been invested in trying to get that adopted, but it didn't happen. And we do have the opportunity of a healthcare reform that is market-based, that is incremental, that tries to improve on the system that we have, and it's the sort of last best hope, it seems to me, of making healthcare affordable and reliable and accessible in this country. We can continue to try to get a Canadian-style single payer, but we have not been able to get the political will. There are many people, I think the biggest, and I didn't say this earlier, but my greatest fear about the success of healthcare reform in California or in the country as a result of the Affordable Care Act is none of the things that we commonly talk about. It is the lack of will. Nobody loves it. Everybody came to it slowly, reluctantly. It isn't their first choice. It wasn't what they wanted. And so we have a delivery system that is lukewarm about it. We have an insurance industry that is lukewarm about it. We have consumers that are lukewarm about it, eager for it to fail so we can go back to the advocacy for single payer. And if we don't decide that this is what we're going to do, it is going to be sand through our fingers. And that is my biggest fear of risk to the successful implementation of healthcare reform.
I have a question for you.
Thank you to the panel for a very stimulating discussion. I'd like to go back to what I think was a challenge from the Secretary, and that was for providers to deal with the problem that Dr. Weiss brought up in his initial comments, which is the fastest growing segment and the largest segment of providers for children's health in this state don't accept government programs, government insurance. What does the rest of the panel suggest we unite behind to advocate in terms of changing policy to bring about a rebalance?
Well, I'll start with that and I'll be a little bit provocative just for the sake of it. We're a state in which the providers are highly compartmentalized right now. And we have two major ones in the state, one Kaiser and the other Sutter healthcare system. And they have very different views about their acceptance of some of the government programs. And oftentimes Kaiser is held up as the model, and it's the model in terms of cost containment, but that's because they're not taking care of some of these individuals who need care because they can't afford it. It's if you can afford it, you can go, but if you can't, you don't, and so their costs are different. I think there's going to have to be a rebase of expectations about who cares for these, in this case, children, but adults as well, or else very much the kind of forecast that we heard from Paul and Diana as well will happen, which is they'll all be trafficked toward one or two or three places, and they won't be able to support the increased costs of dealing with them. And then the system does crack. So I think there needs to be a better societal calibration and a better set of expectations, and I do think this is where the government is going to have to be involved in terms of setting some of those expectations, because denial can't be just a ready option.
Well, and I think that the issue of risk selection has been what our entire system has been based on. And that's why they don't take these patients, is because they're expensive. And the idea of an exchange and the two sides of guaranteed issue, which means the insurance companies can't have any pre-existing conditions. Guaranteed issue means they issue insurance to everyone. And the individual mandate is the other side of it, so that the people who don't think they are sick and don't think they need any health care will have to buy insurance. And that's about having everyone in the risk pool. And you can do that through single payer, or you can do it through the system that has been established under the Affordable Care Act. And until we get a better mix, and that's our challenge as we try to get this health benefit exchange up and running, is avoiding the adverse selection that has doomed every other effort. The PAC Advantage, that was an employer-sponsored program in the 90s, almost made it, but it collapsed because everyone who needed something, they needed some kind of care, enrolled. And you can't, everybody insures their house, but they don't want it to burn down in order to take advantage of their insurance. But in health, we buy insurance, but we expect to use it. And so we only want to buy it when we think we're going to use it. And that's a whole that's why it's a false market. It isn't a marketplace like insurance would work in any other kind, unless you put everybody into the pool and everybody pays something and everybody pays for it. It's the ultimate common good. We are in this together for the common good. Yeah. And that is going to be the biggest challenge to making this work, is having a broad enough risk pool and getting the Sutters and the Kaisers, and that those are just Northern California. There are Hill Partners and Monarch and others in Southern California as well.
But the inadvertent consequences of the healthcare exchanges are also an issue in terms of how they balance between the private payer and the public systems as well.
Right.
So there are lots of issues that are going to be weighed out. I would add to the first questioner that there are experiments going on in single-payer system. Vermont is about to adopt one. That will be a very interesting experiment to see. As many know, I have been an advocate for a single-payer system. I haven't been wouldn't precede the term with Canadian, because I think that engenders all kinds of other issues. But there are lots of other systems around the world that work far better than the one that we have in this nation.
The other thing is that there has been a kind of vacuum of political leadership regarding this issue. Before coming here, I too came from the People's Republic of Massachusetts, and there was a rise in the infant mortality rate in the urban centers in Massachusetts. And the mayors, the attorney general, the governor said, how could this happen in our state, in our city, Boston? Sat down with the CEOs of hospitals, the insurance plans, and said, this is unacceptable. This is too much fragmentation. Nobody's taking responsibility for anything. Figure this out. We're going to come back in 3 months, and you have a plan put in place where you take responsibility for the health of our communities. Indeed, they did. And I don't see that happening here in California at a county level, at a municipal level, or at a state level. That nobody is banging heads together, shaming the various groups, and creating an infrastructure of cooperation and coordination that would insist upon a more coherent long-term strategy. That's been one of the shocking things about my migration west.
Yeah, that's a good point.
Jay Jackman, forensic psychiatrist here. What is it that distinguishes the European systems that they can provide the care that we don't at a fraction of the price that we pay?
Well, biggest difference is salaries. I mean, 80% of the cost in healthcare is in what we pay the healthcare providers. And all over Europe, everyone makes less than they do in this country. It is a very, not just in the providers, in the physicians and the hospitals and the for-profit and the nonprofit, but also in the device manufacturers, in the pharmaceuticals. The pharmaceuticals put all of their research cost on the California prices, on the American prices and not on the international prices. I think there's extraordinary difference, and that's what in Japan. The average income for physicians in Japan is under $150,000.
Yeah, but just to put a slightly different perspective on that, the overall costs for physicians is 11% of the entire healthcare cost market, but physicians account for over 60% of healthcare expenditures. So there is an association. It's not just
Right.
the salaries. I agree that there
I didn't mean
are
just physicians either. I
differences.
meant
Yeah,
everyone.
I know you did. But I think the big issue is in fact the very thing that we discover. It's the use of technology, the unquestioned use of drugs. This country has no cap on healthcare expenditures, so it just rises. If we were in the UK every year, they would set a healthcare cap, and that would be how much the nation would spend. We don't do that. So, now we're approaching 18% of the GDP, and we continue to spend more. So, I think that the date when we'll get really serious about healthcare in this country, unfortunately, is when China calls in our debts. And then we're suddenly going to have to deal with issues that we haven't dealt with up till now.
Thank you. I just really wanted to make more of a comment about what Dr. Joshi said about the role of schools. I think that we are not using schools to the great extent that we could. And I think that in terms of both physical health and mental health, we have access to children there. We can do more of case management. Certainly, we can follow up with more health education of the children. I think that Dr. Joshi's program actually in the schools really is a wonderful model for working together with the schools, working together both in the area of prevention and intervention. And for some reason, I don't know why we don't bring schools more into the equation or into the puzzle as a very large part. We have access to the children. We see the increase in chronic illnesses, on and on. So I hope that we look more at his model, and we can expand that not only for mental health, because his model has worked in our schools. I work in the schools, and but also in terms of physical health as well.
Yeah.
Thank you.
Hi. So I heard multiple mentions of promotores, of medical home, pediatric home, and I feel like there's consensus, with you all that that's sort of the direction that ideally we would be going in terms of the system of child health care and maybe adult health care as well. And I'm wondering sort of, is that actually, is there agreement that that is where we need to be going? Is that, do we know that that is effective? Where is the research on that? And if so, on what level, or how do we see that transformation happening beyond the fact that there's, the economic aspect? Who needs to be making these changes? Is it that there's still just this analysis research end, or is it the practice? Is it that we need just more public support and just more information about how you see that transformation happening? Yeah.
Well, I'm not going to speak for everyone about whether there's consensus. I think that that is the direction that we're going in. It's clearly the underpinning of the National Affordable Care Act, and it will change as the payment structures change. There are several pilot projects that have begun in California. We started in June to mandatory managed care for seniors and persons with disabilities. That was very controversial, that we have a concept of choice, that people should be able to choose which plan they're under, which insurance plan they have, and whether they're paid for by government or not. We are experimenting with that with seniors and persons with disabilities. We have the CCS, the California Children's Services, request for proposals for pilots in that way, and there are 4 different models that we intend to test, and we're initiating a request for proposal on pilots for what are called dual eligible seniors and persons with disability that are eligible under both Medicare and Medi-Cal. There are certain things that Medicare pays for, certain things that Medicare doesn't, and if you're low income, the Medi-Cal can pay for it. There's not good coordination between those 2 programs, Medi-Cal and Medicare. So those are 3 areas where we're moving forward with pilots to test how effective they can be, and incentivizing the participants with shared savings. So we take a baseline of the rate of growth of cost that exists now, and if we can change that, the difference would be shared with the government and with the providers.
Last question.
There are many points, excellent points raised. There was just one particular issue raised that I have a tiny idea that I think might help the issue and both quality and the cost. And that is the issue of so many subspecialists, both for the seniors, it's also for children. If you see a child at Packard and then you have all the primary care physician, you have to coordinate in multiple records at multiple sites.
Yeah.
Some of these countries that have much lower cost and a better infant mortality rate in some of these health indices have, well, maybe because they have a national system, they have a national card where they have all the electronic record on one card. So if somebody comes to Stanford, we don't have to call 3 primary physicians over 3 states.
Yeah.
And also, patients can't shop for painkillers from three different physicians. Now, and the time that you need to sign the consent, come in and, with all the privacy issue, because it's their card. If you give it to somebody, you give them the, so there's a lot of administrative cost and improving communication. Now, I understand if the day you implement that, if you do, everybody will be pulling out their hair when we went through the initial electronic transmission. But in the long run, there are a lot of benefits, and maybe there's some cost effectiveness. Have you ever considered that?
Yeah. So,
Yeah, there are great incentives in the Affordable Care Act for electronic medical records and individual records as well, but the privacy issues are, there are privacy issues with an individual record, but in the sharing, there are issues among the providers, and some of those are related to proprietary systems. The providers, Sutter, for example, or Kaiser, that have gone out and developed a very robust electronic medical record system, aren't so eager to have you take your information and go to someone else if they want to hold you as a patient in the system. So we're working on those issues. They're not insurmountable, but we are working. There's another exchange called the information exchange. So I always say the benefit exchange, the information exchange is sort of the superhighway trying to connect all of these medical record systems that physicians and hospitals and community clinics are developing.
Yeah. But I agree with that. And I think the point that I would add to that is that the extension of your comment really speaks back to your question about the patient home or family home. It's all about coordinated care.
Right.
And right now we have a highly fractured level of care, which generates a lot of the expense. And in other nations where there's been a system in place, you can manage the healthcare delivery system. I was at a discussion last week with leadership of the AAMC, in fact with the Council of Teaching Hospitals and the Council of Deans together about how to craft the future, sort of to your point. And it began with the recognition that when we look at workforce, who's going to deliver the care, it's right now governed by individual market-based issues rather than a rationalization of who should do it. We probably don't need endless numbers of new physicians if we had other providers who can work in tandem with them, but the systems don't speak to that or work collaboratively around that because the patient has been left out of the center and all these forces are moving down their own market-driven pathways.
Right. And
that's where, if we could begin with the charge, I guess the former governor is now denying that he had a role in this, but of Boston, of Massachusetts. But there's something to speak to, setting a charge of let's think about the big picture and really do it well. Maybe that's the message to carry back to Sacramento.
Thank you.
I want to thank the panel and want to thank you for joining us.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.